Assalamualaikum, good morning and welcome everyone. Thank you for joining us for this month's weekend with IAPMD. So my name is Dr. Intan Nurjanah Darwin, pathologist from HSA Johor Bahru, and I will be moderating today's session titled as Clear Vacuolation in Organs, Spectrum of Autopsy Findings. On behalf of the IAPMD committee, I would like to extend a very warm welcome to all of you. We appreciate you taking time off your busy schedules, especially on weekends, to join us for our session today. We hope you will benefit a lot from today's session as we have it lined up for you to be fruitful, engaging, and very informative. Before that, just a few housekeeping announcements before we get started. First of all, kindly turn off your cameras and mute your microphones on your devices to avoid any interruptions. If you have any questions during the presentation, you can type them out into the chat box in your control panel above. We will bring them up during the Q&A session after the presentation. So now, without further ado, I would like to turn the time over to our guest speaker of the day. Definitely not a stranger to our line of work, though he does deal more with the deceased rather than the living. Dr. Khairul Zainun is a forensic pathologist and head of forensic medicine department of Hospital Serdang, Selangor. He is a medical graduate of Otago University, New Zealand. After completing housemanship training in Hospital Ipoh, he served as medical and health officer at clinics within Kinta district in Perak. He returned to Hospital Ipoh to work at forensic medicine department and later pursued postgraduate training in forensic pathology at University Kebangsaan Malaysia. He had previously served as forensic pathologist at Hospital Kuala Lumpur, Hospital Sultanah Aminah Johor Bahru, and Hospital Sungai Buloh prior to assuming his current role at Hospital Serdang. Dr. Khairul Anuar has a special interest in pediatric death investigation. He traveled to Sheffield Children's Hospital, United Kingdom for subspecialty training in perinatal and pediatric pathology, focusing on sudden death investigation in infants and children within Sheffield and its surrounding regions. His other interests include quality assurance and performance standards in forensic pathology. He enjoys teaching and is an active researcher with published articles in peer-reviewed journals. Dr. Khairul Anuar is a member of College of Pathology, Academy of Medicine Malaysia, Malaysian Medical Association, and Malaysian Medical Legal Society. I am very fortunate to have had the greatest privilege to work alongside him at Hospital Sungai Buloh during my master's program. Without further ado, we are humbled and honored to call upon our guest speaker to share his presentation today. Dr. Khairul Anuar, the floor is all yours.
Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. Thank you very much to Dr. Intan Nurjanah for such a kind introduction. I would like to also thank the IAP Malaysian Division for giving me this opportunity to talk during this weekend with IAPMD session, which I would say initially when I was invited, I felt extremely excited and honored. And I think I quickly agreed and accepted the invitation to talk about autopsy pathology during this session. But only later on I realized that this is not an easy task because although autopsy pathology is very much close to my heart, but I'm no longer talking to a forensic pathology fraternity. And on top of that, I was reminded to refrain myself from talking about pediatric autopsy topic, which is another area that close to my heart. So I suppose after a few head-scratching sessions, trying to figure out the topic, at the end, I finally concluded that maybe this is the suitable one, and hopefully it can be beneficial to the trainees who are collecting autopsy cases, right up to experienced anatomical pathologists who are conducting clinical autopsy cases. So this is the topic today. I will share first the screen. Spectrum spectrum of clear vacuolation at autopsy. Do you able to see my screen?
Yes, doctor.
Okay. And first and foremost, I would like to declare that there are no conflicts of interest in relation to this presentation. And as I mentioned, I hope this is going to be the outline, and at the end of the day, able to highlight the histology, autopsy histology of clear vacuolation, which can be detected at autopsy and can be part of that finding as well. And at the end, highlight the significance of the finding. And I will do this along the way by sharing some of the cases that I encountered in the past. And hopefully this kind of talk should serve as what is intended by Weekend with IAPMD, santai enough, suitable enough to be shared with friends and colleagues during this Saturday morning. Now, as for introduction, clear vacuolation that we are going to see in this presentation, they are essentially fat or lipomatous change, which can be seen at various organ at autopsy. And as exemption, there is one case or organ which they are not really contain fat, they are not representing of fat, they're more of a glycogen, which is a stored form of glucose in the organ. So how often this incident of clear vacuolation detected at autopsy, it depends on which organ, and some which is definitely more common compared to the other. But the changes can be seen in other organ, can be representing of very important pathological entities. And as from where the cases can come from, it can be from a natural diseases as well as trauma. And more importantly, when it comes to this clear vacuolation detection, it's more important to understand the significance of them, whether they can be as indicator of systemic diseases. And from autopsy perspective, it is very important to acknowledge whether such detection may in fact finally can be opined as the cause of death, or in fact can be significant contribution towards death. And in some cases, although we are able to detect them at autopsy in various organs, they may in fact, from the overall interpretation of the finding, it may in fact represent just an incidental finding. So by sharing some of these cases that I encountered at autopsy, I will try to highlight their significance and try to figure out and at the end of the day able to interpret them accordingly. Now, I will do that by sharing these cases from one organ to another. And I would like first highlight the first organ, and by outlining also the case history of the relevant case history. So this is actually a 50-year-old man with no known case of diabetes mellitus, and he was on regular medication, and he was found a complaint of sudden onset of restlessness and eventually collapsed at home. So he was eventually brought by the family members to the emergency department of the hospital, and despite active resuscitation by the emergency department team, he was later on pronounced dead in department, or DID. So this case eventually ended up having a forensic postmortem done. External examination showed a jaundice sclera. Both lung shows foci of hemorrhage, and one of the ancillary investigation that was taken at autopsy, which is microbiological analysis for PCR, was detected for leptospirosis. So this is the autopsy finding of this particular organ, which is the liver. It was actually enlarged with diffuse fatty change throughout the whole liver. And the photo on the right upon cross-section shows fatty change discovered as what the photo on the left shows throughout the whole liver. And the following subsequent histology shows these changes. This is the clear vacuolation, fat infiltration within the hepatocyte, which is diffuse and associated also with some changes like podocyte inflammation. And if we go more detail, we may show with the appropriate staining shows a fibrous bridging septate start to also seen. But if you notice the vacuolation, consist more predominantly mix of micro and macrovesicular changes. They are in fact distributed diffusely in all the sections taken at autopsy. So this is hepatic steatosis, which, as I mentioned previously, they're very common autopsy finding in any kind of cases that undergo an autopsy, whether as a forensic or clinical autopsy. And as what has been shown from the histology, they compose more of micro and macrovesicular vacuolation. The changes can be seen from the gross liver itself. They tend to be enlarged with fatty change. They can be not totally diffuse like what we have here in this case. They may in fact can be only seen, the fatty change can only be seen focally. But in overall, it is has been commonly associated with alcohol abuse and non-alcoholic fatty liver disease as well. But the two significant thing about this finding is the subsequent end-stage liver disease, which can be at the end derived from these two conditions. So as for alcohol abuse leading towards cirrhosis, if it is not reversible in that situation, that would be the subsequent end-stage liver change, and ultimately will be also seen externally from the postmortem external examination or the stigmata of liver disease. But as for the non-alcoholic fatty liver disease, there is a lot of literature has been produced and showed the connection between NAFLD with DKA, or diabetic ketoacidosis. And this is especially true if it relates, especially in the case of those who are not known to be diabetic before their death. And these are the common changes has been detected in autopsy of such cases. So non-alcoholic fatty liver disease, together with all the constituents to diagnose diabetic ketoacidosis, they are quite common to be found together in autopsy of such cases. And this is one of the paper published by Lal et al., which is talking about liver pathology in first presentation of diabetic ketoacidosis and autopsy, published in Academic Forensic Pathology. What about the significance of this finding? As for the NAFLD, apart from having the potential having end-stage liver disease as the endpoint, and in fact as the cause or possible cause of death, non-alcoholic fatty liver disease also has been commonly associated with cardiovascular disease. So in some other cases, apart from finding this clear vacuolation in liver, the cause of death in such cases can be from cardiovascular diseases. And apart from the heart itself, pathology detected from the heart, pathology, for example, associated with pulmonary thromboembolism can also be one of them. So upon finding of histology of hepatic steatosis with interpretation of subsequent to non-alcoholic fatty liver disease, it can be part of that overall presentation, although the cause of death may in fact relates to cardiovascular disease, for example, pulmonary thromboembolism. The other potential cause towards hepatic steatosis finding like this can be associated with drugs abuse or even toxicity of certain medication, for example, like paracetamol. And in a forensic setting, cases like heat stroke or even starvation also has been associated with hepatic steatosis changes like this one. Should the histology of the steatosis also concurrently shows hepatic necrosis, the potential, the possible differential diagnosis should also include infection by certain organisms, especially viruses. And then don't forget that there's a possibility also such hepatic necrosis with concurrent steatosis is actually part and parcel of ischemic injuries or even exsanguination of blood from any possible causes, not just from trauma related. And this is something that also been commonly detected, especially those cases involve sudden unexpected death in children. When the autopsy is performed, they are also turn out to be changes of hepatic steatosis. More has been connected to obesity, which can be quite rampant nowadays in pediatric age group. But the other important potential that need to be also think about is the metabolic diseases, which can be one of the potential or differential diagnosis of sudden unexpected death in children as well. So this is another paper by Hardy and Morotti, which is highlighted in detail about pediatric obesity and changes in the liver that can be detected, including hepatic steatosis. I will move then now to second organ. I will describe as well the history of presenting history of the case. This is 25-year-old postgraduate student, a known case of IDEM, insulin-dependent diabetic mellitus, and on regular insulin injection. At one point, was unwell with fever and few URTI symptoms, went to GP, and was treated for the URTI and prescribed antibiotic, but unfortunately was found dead inside the room of the university hostel. Now, external examination is very much unremarkable. Essentially, this is commonly described as a negative autopsy. But the changes that's seen in this organ, which is the kidney, shows like this. This is a slide taken from the from the junction of the corticomedullary junction. It highlights the central glomerulus over here and the surrounding tubules. What is actually seen here, this is not the low power view. The surrounding tubules shows a clear vacuolation. There is some element of congestion of the vessel. The congestion also can be seen within the capillaries of the glomerulus, but the striking features here is the clear vacuolation within the tubular cells of the the kidney and within this corticomedullary junction. And in high power view, this is how it looks like. Perhaps this is not as good as is commonly seen in the atlas, essentially due to the fact that when autopsy been done, there's some element of decomposition already set in, and therefore we cannot run away from seeing some decomposition or autolysis changes in the tubular cell as well. But apart from that, we can see clearly here some element of clear vacuolation within the tubular cell of the kidney. And this is on further high power view, more or less the glomerulus doesn't show us that usual changes seen commonly in diabetic status cases. But the striking point, as I mentioned just now, apart from the blurring secondary to decomposition changes, these are the change of tubular vacuolation, tubular cell vacuolation. So essentially, this is what we call Armanni-Ebstein lesion. The vacuolation seen as what we see just now within the tubular cell of the proximal tubules. They are commonly within the corticomedullary junction, or even more common within the external medullary area, the outer medullary area. Instead of containing fat or lipomatous change, it is in fact actually glycogen accumulation. So therefore, they are positive cells. So this has been this phenomenon or lesion has been highlighted and documented as a marker of ketoacidosis. And this is especially true in poorly controlled diabetes, as well as those consume significant amount of alcohol, especially that relates to binge drinking. And a more literature has been highlighted that the changes of Armanni-Ebstein also can be seen in starvation case, and recently also in hypothermia. There is another scenario whereby in the case of poisoning that commonly associated with forensic autopsy, the nature of poison that has been detected is isopropanolol. This is in fact original name is isopropyl alcohol, which can be one of the derivative can be seen or part of constituent of hand sanitizer or hand rub, which if it is being misused can lead to poisoning. In this case, isopropanol poisoning, and upon autopsy, upon histology analysis of the kidney, the finding of Armanni-Ebstein has been commonly described. And for that reason, it is in fact very important as part of autopsy to make sure that ancillary investigation, those important ones need to be sent as well. So for ketoacidosis, it is important to send urine for ketones, and because it also this scenario or this systemic illness involve inappropriate or glucose level metabolism derangement, it is also important to make sure that glucose has been detected or has been sent for appropriate analysis. But as all of us knows, glucose in diseased body in blood is not a stable analyze, and therefore from autopsy perspective, in order to make sure that we don't miss sending or detecting glucose in the body and searching for the most stabilized analyte within the body fluids, it is in fact is actually more stable, this glucose in vitreous fluid. So sending vitreous glucose is very important, and it also has been proposed another analyte, which is beta hydroxybutyrate, which is commonly associated also with ketosis But unfortunately, I think as of now, if our chemical pathologist colleague can also agree with me, we are not able to do this yet, especially when it comes to vitreous fluid. So, and therefore, to the minimum, we should send urinary ketones and also send vitreous glucose to get the necessary results in order to support these ketoacidosis changes when we find this Armanni-Ebstein lesion within the kidney. And by now, it has been commonly accepted with the finding of Armanni-Ebstein lesion with high level glucose within the vitreous and detection of ketones in the urine with appropriate history supported by other changes, either external or internal examination. And together with what we've seen just now, the non-alcoholic fatty liver disease, the clear vacuolation, the hepatic steatosis in the kidney, in the liver, we can reasonably conclude that such death, despite negative autopsy, can be due to as a result of diabetic ketoacidosis. This is another paper produced by Milroy and Farai, highlighting the role of Armanni-Ebstein lesion and the post-mortem diagnosis of ketoacidosis published in Academic Forensic Pathology Journal back in 2012. I move now to third organ, and the case is more or less about this. It is actually 25 years old man, very well and healthy, who went for evening jog, which he periodically does every day, every other week around the neighborhood. And upon 10 minutes of the event, he complained of difficulty breathing and subsequently collapsed. And those joggers that are also present in the neighborhood area that he went for jog came to his rescue and brought him to emergency department of a nearby hospital. But unfortunately, upon arrival to emergency department, he was pronounced brought in death by the respective emergency department team. Now, at autopsy, subsequently performed for this case, it was again very much negative autopsy from external examination and the rest of the internal examination. But the only, in fact, when it comes to the heart, this is how it looked like. Essentially, you can see the dimension of the heart is more or less almost normal looking. There's no increase in weight. And upon further sectioning of the coronaries, as highlighted in the yellow circle here, the state of coronary arteries were very much patent. And further dissection of the heart, looking at other structures, the chambers as well as the ventricles in terms of their thickness, right to the condition of the valve, they are also normal. But upon histology, this is what has been shown on the histology of the right ventricle. So another clear vacuolation, fatty infiltration, lipomatous changes within the ventricle, the right ventricle of the heart. And they are quite enormous in terms of their distribution. And upon Mason trichrome staining, you can see fibrous tissue mixed within that lipomatous changes. Another similar case also involved another young man, 19 years old adolescent, without no known illness prior to his death. This is quite an old one, but I'm just highlighting and sharing here. We used to have a PLKN training program before. So he actually attended this training program, whereby it consists of a few evening exercise activity. And it was during this exercise activity following this program, he complained of a little bit unwellness, and eventually, after conducting his Asa prayer, he collapsed and later on became unconscious. And he was subsequently brought to the local hospital, but unfortunately he was pronounced brought in dead upon arrival to emergency department. And again, external examination shows nothing much. Internally, the heart also almost exclusively unremarkable. They were from a perspective of parameters and weight within a normal range, but the right ventricle again shows these lipomatous changes, and they were in fact quite extensive, with the foci of them within the right ventricle, and also again with the benefit of mesenteric can highlight the fibrosis. And the photo on the right also shows a little bit infiltration by infiltrates. So this is, in fact, compared to the first case, the second PLKN case here shows these changes, lipomatous changes, fibrolipomatous changes, in fact, within the anterior and posterior wall of left ventricle. So as compared to the previous one, which is only limited to the right ventricle. So this is essentially arrhythmiogenic right ventricular cardiomyopathy. By now, it has been quite commonly detected in sudden death that occur in young adults. At one stage in Hospital Johor Bahru previously, there was a study done looking at those deaths below 40 years old, although ischemic heart disease is still predominated, but a significant portion of percentage of this cause of death were actually coming from ARVC. So what happened in this condition? This is essentially muscle problem. It is associated with genetic aberrant. The defect is in fact within the genes that encode the protein, the desmosomal protein. Desmosome or desmosomal protein essentially is a connecting protein between one myocyte to another. So having this kind of defect, the connection have become loose and eventually dies out, and the myocyte also will be become atrophy and later on replaced by fatty change or lipomatous change. When these conditions were first mentioned in the literature and subsequently more cases discovered, there were two variants has been proposed. The first one is actually purely lipomatous change, while the other one is actually fibrolipomatous change. So the two variants. But what both variants commonly share, the fact that the myocyte become atrophic and then replaced by the fatty infiltrates, and also by now later on has been discovered cases whereby they are also associated with lymphocytic infiltrate change. So this is another two papers, although they are quite not very recent, but the ongoing discovery also has been associated or suggested that, in fact, this condition is not purely a condition of the right ventricle. So, in fact, there's also cases whereby the involvement, as what we show, as what we note, as what we saw from the second case, the involvement of the left ventricle also has been quite commonly discovered. And that brings to the fact that, in fact, maybe possibly this is not purely as what has been proposed earlier, condition strictly within the right ventricle. It is actually can involve the left ventricle as well. And therefore, it's been proposed by now, in fact, the umbrella condition of this remain as arrhythmogenic cardiomyopathy. And that's to include both the right ventricle as well as left ventricular involvement. What happened having that lipomatous change, having that clear vacuolation changes within the heart, it is actually can become a point, a focal point, or a nidus for arrhythmia. It simply disrupts the electrical activity, the conduction system of the heart required for proper contractility, and it can lead to sudden collapse. And the nature of arrhythmia has been documented regularly and seen published within the literature is ventricular tachycardia. And for that reason, by now, in certain countries like European countries, there is a screening has been proposed for certain activities. For example, pre-participation screening for vigorous exercise activities. This has been proposed by certain countries in order to detect this condition, especially for young adolescent or young adult, in order to prevent sudden collapse. And they are actually using the ECG and trying to detect the ventricular tachycardia as well as other type of arrhythmias. But apart from presentation of arrhythmic condition leading to sudden collapse, it's quite often this condition has been presented with failure symptoms. And by this nature, upon collapse and finally if autopsy being performed, commonly also detected secondary findings within organ like pulmonary edema, hepatosplenomegaly, as well as histological changes of passive congestion. So these are the two mode of presentation, the two mode of death, and different and the way it can be presented differently within the age group of young people, both sudden collapse due to arrhythmic episode as well as failure symptom, which can be more lengthy in terms of period of symptom development. I'm also highlighting here the fact that when it comes to diagnosis of ARVC or arrhythmogenic cardiomyopathy based on histological finding, apart from looking for the criteria in order to establish the diagnosis, this is one of differential as well, the adipositas codis, or which or simply means fatty infiltration within the heart muscle, which is commonly occur in aging as well as obesity. But I suppose in comparison to ARVC, adipositas codis is merely involve fatty infiltration without presentation, without due to myocyte atrophy as what normally seen in ARVC. And the other striking features is the fact that within histology of adipositas codis, the nature of infiltration is purely lipomatous change or fatty infiltration. They lack element of fibrous tissue as well as lymphocytic infiltrates. But of course, in terms of the overall opinion with regards to the cause of death or even the significant contribution towards death, the diagnosis, the final cause of death should be not just purely by histological changes, as what the forensic practice is commonly done. It should also take into account the other presentation of illness as well as other ancillary investigation that should be done as part of the overall autopsy itself. Now, the fourth organ, which is the final organ here, I'm highlighting this case, which is actually a 3-year-old boy who was well and healthy prior to his death. Well, apart from claimed to be by the mother quite shown a hyperactive behavior, he was actually well and healthy. From social history perspective, he lived with the mother and a stepfather. And on that day of event, when the mother left him with the stepfather, at one point during in the afternoon, he complained of vomiting a few times, which made the father seek for medical attention. But it was not done in a rush, only after a certain period of time, whereby it involved about 3 to 4 hours later, after episode of vomiting has been continued for many times. But unfortunately, upon seeking medical attention, he was pronounced dead, in fact brought in dead upon arrival to emergency department. It was during the examination by the attending emergency department team, it was discovered that the boy had a suspicious bruise over the abdomen. Now, at autopsy, the case ended up having a forensic autopsy done, has been investigated as under non-accidental injury. In fact, it was true the suspicious bruise was detected, in fact, at autopsy, although the nature of bruise or contusion only confined to one focal area over the abdomen within the epigastrium region. But upon sectioning of the internal organ as part of autopsy practice, sampling of the lung histologically shows these changes. So the nature of aeration here, as can be shown from this histology, they were mix of both, while in fact highly aerated with another collapse area. But within that parenchymal vessel, you can show a clear vacuolation, not just the bigger one, but also the smaller one. And in fact, within the congested collapse area of the parenchyma, we can still see a lot of clear vacuolation within smaller vessel, right down to the capillaries of the interstitium. This is in fact a case of fat embolism, the clear vacuolation representing fat that travel from a distant area right into the pulmonary vessel and cause pulmonary fat embolism. And for this case, the changes of fat embolism can be seen quite extensively and diffusely within all the section lung of all the lobes that involve. So this is quite common, the clear vacuolation of fat embolism, pulmonary fat embolism in blunt injuries, in particular to this case, following impact of a suspicious contusion on the epigastrium detected. Part of the internal autopsy finding also detected torn mesentery with associated rupture of the jejunum. So upon this torn mesentery, with a certain period of survival involved, enough for this fat to enter the circulation from distal side of mesentery right over towards the pulmonary vessels. And apart from blunt injuries of assault, like what I highlighted just now, it can also be seen in cases of motor vehicle accident or even fall from certain height, and also burn cases. And perhaps burn cases tend to be involved deeper layer of burn, of the skin, or what we normally categorize as third-degree burn injuries. But the only thing that tend to share between all of them, all of these cases, the fact that it normally involves delayed death or a period of survival before demise, as what has been shown here in this case that involved the 3-year-old boy. And that's for that nature. With that understanding, we know that this is exactly will take some time for the embolization to occur and in fact travel to the pulmonary vessel and subsequently giving the appropriate symptom and sign of leading towards collapse and consciousness and failure of the respiratory system. I just want to highlight as well, apart from pulmonary fat embolism, it can also travel right up to the brain and causing several embolism. And from the perspective of cause of death or contribution towards death, it is commonly accepted that should it only involve pulmonary detection, only involved within the pulmonary vessel, subsequently diagnosed as pulmonary fat embolism, normally it requires some of the element concurrently in order to reasonably conclude as a cause of death. But once it involves cerebral embolism, cerebral fat embolism, this is involve two major organs, lungs and brain, and it can be reasonable to conclude this is significant enough to cause death from these two main organ systems. So with that, this is my take-home message. This clear vacuolation, they can be common autopsy finding depending on which organ they're involved. Or most of the time, this represent the fatty infiltration or fatty change or lipomatous change. It can also be seen in the kidney as per Armanni-Ebstein lesion. They are, in fact, instead of fat, they are glycogen. They can be a marker of systemic illness. Like I mentioned, in diabetes ketoacidosis, in fact, it can be accepted now as a significant finding in the diabetic ketoacidosis, although it is not commonly only reserved for diabetes. We have also come across cases whereby the same changes seen in alcoholic as well as starvation ketoacidosis. But on the other note, this clear vacuolation can also be seen and represent a very distinct or specific pathology entity, as what we saw just now in the case of arrhythmogenic right ventricular cardiomyopathy. But from both perspectives, the death can occur from both natural diseases as well as trauma-related. And at the end of the day, it is important for us to make sure and decide, after taking into all the consideration, not just the histology finding, but all the other ancillary investigation as well, to decide on the proper cause of death, or even the finding can be only merely contribution towards death, or even lower than that, it may just be an incidental finding at autopsy. So with that, thank you very much.
Okay, thank you very much for the very informative presentation, Dr. Khairul. As a pathologist who reviews cases which show clear vacuolations that are often neoplastic in origin, it is good to know that we have gained new knowledge on other organs exhibiting these clear vacuolations as well that are secondary to medical comorbids instead. So hopefully this session will be beneficial to the trainees going for exams, as well as the histopathologists when handling clinical autopsy cases. So now, if anyone has any burning questions, I'm sure Dr. Khairul Anuar will be pleased to answer them. Just a reminder, please be sure to type in your questions in the chat box in the control panel above. You can also turn on your microphone and ask Dr. Khairul directly. So far, there are no questions asked. Maybe we can give a few minutes to see if there are any last minute questions to be asked. But I do have one question. Just now, the fourth case you presented, Dr. Khairul, the assault case, the pediatric one with the fat embolism, you mentioned that fat embolism can be seen in histopathology. It might take some time to be seen. So how long duration is it actually found on histology? Can it be immediate or days?
Yeah, so based on cases that we encountered, it is normally involved within a few minutes to even a few hours. So, but I'm not totally discount the fact that it may take longer than that, depending on the nature and severity of the injury or the site where the fat originated. So, for example, in cases like assault just now, it was detected at autopsy. The lesion that involved the mesenteric tear can be categorized as quite a small lesion. Which is somehow correlates with the clinical presentation, requires or involve at least about 4 to 5 hours from the initial impact of the trauma towards the first presentation of vomiting and in fact later on collapse upon arrival to hospital. But there were some other cases whereby the origin of the fat were coming from subcutaneous tissue upon trauma towards that the body as well as both limb, or in fact all four limbs, the upper limb as well the lower limb. So in this case, we noticed that upon involving more or extensiveness of the injury tend to be very much more well distributed throughout the whole body. Somehow the nature or the timing of embolism also based on the clinical correlation of presentation, they tend to be much quicker compared to the focal impact as what has been experienced by that boy illustrated by that case. So those extensive involvement of trauma over the body leading to fat embolism syndrome, pulmonary fat embolism, in correlation to clinical presentation, they even 1 hour. They were found to be less than 1 hour. So it varies in overall.
Okay. Thank you, Doctor. Otherwise,
Doctor, I have one question, Sugunaya.
Yes, sir.
Just now you mentioned the ARVC. There are two types of two forms, right? One is the pure fatty infiltration into the ventricles, and the another one is the conventional, the typical type that we saw with fibrofatty infiltration with lymphocytic infiltrates. The first one, the pure form, which is just merely adipocytic infiltration, how we want to differentiate it from the perhaps maybe atrotropic adipose tissue in the ventricles?
Yeah, exactly. This is actually with regards to this type, which is purely lipomatous change. It can be quite challenging to diagnose or to differentiate with the other, which is purely adipositas cordis, which is purely fatty infiltration within the heart. So, so in overall, our based on our approach, it should correlate after with the other information as well. For example, the clinical presentation, the demographic detail of the case, the detection within which area of the heart, and as well as the nature of extensiveness of the infiltration. But I agree that can be quite challenging to differentiate between this pure lipomatous variant of ARVC in comparison to the adipositas cordis, especially if it is nothing else that been shown compared to the another variant. So my recommendation, I think, as what the publication and literature suggests, it should also taken into account the other information that comes with the case, taken into account the autopsy finding as well, the nature of external finding, whereby in adipositas cordis, it is actually quite often relates to case of obesity as well as increased age or aging population or societies. So depending on the demographic detail of the case, hopefully that can be also used in trying to differentiate these two conditions. But having said that, there were few published literature has been saying that for the nature of ARVC itself, in terms of the two variant, the first one, which is involved the fibrous tissue as well as the lymphocyte infiltrates, is actually more commonly accepted to represent the pure the exact nature, the exact histological changes that should be used in order to diagnose ARVC. But I'm just highlighting that at one point, this is another variant which is purely lipomatous has been proposed previously.
Okay, I guess we have no more questions. All right, Dr. Khairul, Anuar, is there anything else that you would like to cover before we wrap up?
I think that's all for me. I think I went beyond time, right?
Yes. All right, so on behalf of the IAPMD committee, we would like to express our paramount gratitude to Dr. Khairul Anuar for being our guest speaker of the day and for delivering such an excellent presentation. We really appreciate you making time for us today, despite your busy schedule.
Thank you for the invitation.
All right. Also to all the participants, thank you again for joining us today. Don't forget to clear your CPV points. We hope to see you again next month. I shall pass over the session back to our host, Dr. Subina. Thank you.